Good afternoon and welcome to the MacLean Center for Clinical Medical Ethics 43rd Annual Interdisciplinary Lecture Series. The theme for this year is Advocacy in Healthcare and Medicine, as many of you know and have attended these lectures before. Before I introduce today's speaker, Dr. Alfandre, I want to remind you that next week, April 2nd, we'll hear from Dr. Sally Sattel from Yale University. Anyone interested in the full schedule can either find it online or grab a brochure on the way out. So today, though, we are delighted. I'm particularly delighted because it's been a friend of mine for many years to have Dr. David Alfandre. David is a physician and the director of clinical ethics consultation for the VA National Center for Ethics in Healthcare. He attended Mount Sinai School of Medicine in New York and trained in internal medicine at Columbia University Medical Center. His interests include medical decision-making and against medical advice discharges, and he is the editor of the book Against Medical Advice Discharges from the Hospital, Optimizing Prevention and Management to Promote High-Quality Patient-Centered Care. In 2008, Dr. Alfandre joined the staff of the VA National Center for Ethics in Healthcare, where he provides ethics consultation expertise to VA field facilities across the VA enterprise, as well as to VA central office leaders. He is currently an associate professor of medicine and population health at the NYU School of Medicine and is a practicing hospitalist at the New York campus of the VA New York Harbor Healthcare System. In his spare times, he builds things mostly out of wood, and we're inviting him back next year to give a talk on the things he builds out of wood in New York. David, it's really like a pleasure. We've been planning this for a year, so very excited. And he's been to the MacLean Center before, we think 15 years ago or a decade ago. For those of you that have been around and remember John Schumann, a friend of John Schumann. So it's really a privilege to have you. Excited to hear from you. So thank you very much.
Good morning. Good afternoon. Can everybody hear me okay through the microphone? Yeah? Okay, great. Let's go with the next slide. So it's a pleasure to be here. It's an honor to be here. Really glad to be back in Chicago. I was at University of Chicago maybe, I think it was 16 or 17 years ago, and I got to meet the MacLean faculty. Just thinking about advocacy, and I remember I got a chance to sit down with Mark Siegler in his office maybe for 20 minutes or so. And when I think about advocacy, I mean, he was on the phone with probably 7 different patients during that time while I was in his office. He really was, and in the time that I spent with him, really an incredible patient advocate. So I drew a lot of inspiration from that. And we love Chicago. I love Chicago. Big Ferris Bueller fans. Home Alone, The Fugitive. I don't know. I have a lot of images of Chicago, and so it's been nice. I've had a couple of days to be able to spend here, so I'm looking forward to it. I have no conflicts to disclose, financial or otherwise. As the introduction said, so I'm the director for clinical ethics consultation at the VA. Our office, the VA National Center for Ethics in Healthcare, establishes and promotes standards for ethical healthcare practice across the VA enterprise. VA is the largest integrated healthcare system in the country. We care for 9 million veterans. There's 140 VA hospitals across the country, over 1,000 outpatient clinics. But I'm not here to speak about the work I do in VA. I'm not authorized to speak about that work. I've taken vacation to come speak today, but I did want to spend just a minute talking about what it means to be a public servant and a federal employee in the federal government. So employees of the executive branch are subject to a range of federal statutes on rules of behavior, ethical rules of behavior. And again, those are established in code. And my colleagues and I take great commitment to those. And they relate to public service, they relate to conflicts of interest, they relate to gift giving. Public service is a public trust, and we cannot use our public office for private gain. We are required to uphold the rules and regulations that ensure equal opportunity for all. And it's been a privilege to work in my office for this time. George Washington said it much better than me, but I've dedicated myself to its service with an upright zeal for 20 years, 2 years in the Peace Corps. And I appreciate the opportunity to be here today and share with you some of the great work that public servants do for this country. So we're going to talk about obligations to advocacy. We're going to talk about the opportunities, the obstacles, how we overcome those obstacles. I'm going to weave in some stories, mostly to keep you interested, but in some ways to sort of engage us in a different way. I'm going to talk about advocacy at different levels. I've sort of broken it in this particular format to thinking about advocacy at the interpersonal level, advocacy at your institutional level, and then advocacy across the healthcare system, and I mean broadly, nationally. So let's start with obligations to advocate. There was a time in my career many years ago where it felt like I was constantly responding to out-of-hospital emergencies, and I don't know why, but it just was. So, you know, someone had an MI at a dinner party. We were skating, my family and me, at Bear Mountain State Park, and someone had a cardiopulmonary arrest. I've responded to suspected CVAs on commuter trains. There's been a range, you know, medical flights, you know, transcontinental flights where people had medical urgencies. So it's very, I like telling the story because hopefully after we can have some conversation about this, but it's very stressful. It's very challenging performing, providing care in those settings. There's no privacy. You're in a very public setting where people are sort of observing what you're trying to do and take care of the person. You don't have the tools, the resources, any of the information that you normally have to take care of people. But again, when I tell people about it, they've always got a different story for me. And so I'm curious to hear the stories that, that other people have had. But my favorite memory from years of doing this, and for some reason it hasn't happened in the last couple of years, it must sort of come in waves. But my favorite memory is when someone came up to me on the commuter train the next day and said to me, "Thank you for responding. It's really good to know that someone was there to make sure that that person got taken care of." And that was really important to me. And I think it begs this broader question about what is our obligation to the public? What is our obligation to serve the community in which we live? And sort of broader obligations beyond that to advocate for better public policy, to rally for support, to work with your government to make changes. What are those obligations? And so I want to talk a little bit more about that as well. So it speaks to this, I'm sure some of you have heard this concept before. It's really more of a metaphor, this social contract between society and the profession. But I think it helps us consider this sort of larger ethical framework for obligations. And this contract says, right, in general, that in exchange for the profession providing necessary and expert services and expertise to the public and committing itself to competence and integrity and altruism, that in exchange for that, society will grant this profession prestige, it'll grant it a monopoly on its practice, right, through licensing, and it'll grant it the autonomy to self-regulate. And baked in with that is these obligations to the public, right, and its public service. And that's what we see in our codes of ethics. And you have a sense of that, and you've probably seen that before. And I agree with those things. So it's within our codes of ethics. But as I was thinking about this talk, I ran across an interesting article that I recommend you take a look at. And it was asking the question, is advocacy mandatory or should it be mandatory? And I think it's a pretty straightforward question. I don't think it should be mandatory. But the argument they made was that physicians can't advocate for health services at the public policy level, because that's ultimately a resource allocation decision, right? That, you know, public policy makers and legislators they have multiple commitments, and whether it's infrastructure or national defense, or, you know, and so physicians aren't at that level weighing the different needs. They have expertise in healthcare, and so that's not something that we should require physicians to participate in. But I have another way about thinking about that, and I would say that advocating for the health and public health and the health of our communities promotes opportunity, right? It promotes individual opportunity to live their best lives, and opportunity promotes liberty, right? So it's not so much about partisan activity, but really about what I think we all agree on and what this country is based on. So I like this concept of a scope of professional obligations that sort of span from obligations to aspirations. So should every physician be obligated to serve their community? Yes, but no, right? I mean, all physicians should be obligated consistent with their skills and their abilities and their expertise. But it's ultimately a collective professional obligation that healthcare professionals have. And it's not necessarily an individual one. But remember that if enough healthcare professionals fail to rise to that obligation, then back to this concept of the social contract, do we lose the trust and the respect of the public if not enough of us are doing that? So I like this figure that sort of helps appreciate it. And so it's sort of our sphere of influence, right? So within the individual patient encounter, clearly we have an advocacy role, and maintaining access to care and certain social determinants of health that directly relate to patient outcomes, then yes, we have an obligation to do that. But as it gets farther and farther out, where the health outcomes don't have a one-to-one relationship to the social determinants of health, then it becomes more aspirational and less of an obligation. And I think that sort of helps address some of this. And when I think about back to the examples I started with, you know, my brother, I'll pick on my brother because he's an orthopedist. If he was on the subway and someone had a seizure, someone would say, well, he's an orthopedist. He doesn't manage seizure disorder. He's not going to know what to do. Surgeons are quite skilled at managing emergencies, right? And so the idea of having someone who is a healthcare professional that's there restoring some calm, some normalcy to a very frightened public that doesn't know what to do, I think has a real potential benefit. So I would say if you can help, and help should be considered broadly, then you should. I think about the best reason, though, that why we should advocate and our obligations, and the easiest way to think about it is because it feels good to help, right? That's why we do it. And you don't have to be a Tolstoy scholar to know that, but it sort of keeps me going in ways when I have some hesitation. So as I said, I'm going to think about these opportunities at different levels. And we'll start with interpersonal, and then we'll go through institutional opportunities and then systems. So I'm going to start with a story at the interpersonal level between healthcare professionals and their individual patients. I'm not going to bore you with stories about what a wonderful advocate I've been to my patients for the last couple of decades, but I'm going to tell you a story about how I've been grateful for the advocacy that I've received and my family has received. So when my son was very young, he was 3, he got very, very sick. It happened very quickly. He's doing great now. He's 19. He's at the University of Michigan. Go Blue. But he became rapidly ill, and it was dizzying and exhausting and frightening. And if you want to read a great story about it, the reference below, that's my wife. She wrote that for the Times. And it's a lovely story of the challenges that we had going through that. But I remember a day when we were in Jack's room, and he had just gotten out of surgery, and some surgical consultants came into Jack's room and were evaluating him. And they were doing an exam and making determinations about what should be done based on their exam. Well, Jack's attending surgeon was next door, heard about this, and came in, marched in the room, found out exactly who asked them to come, because he didn't, found out what they were there for and what they wanted to do, and promptly dismissed them. He was in charge. He didn't want anybody on the surgical team that he didn't know about, that he didn't ask for. He didn't identify that this was a clinical need that needed to be addressed by this particular clinical consultant. And we saw that as real advocacy, right? I mean, we had tremendous trust in our surgeon to begin with, but this was someone who was stepping up, taking action, doing something, and built trust in a way that I like this idea. This doesn't come from the healthcare literature, but building trust is about having confidence in the unknown or the uncertain. And I think he moved us towards that, and took action, or that you might argue that he prevented action. We sort of, my wife and I talk, she's a physician as well. We talk about what we learned in residency with the famous phrase of "don't just do something, stand there." And this idea that again, he was a tremendous advocate for Jack, and it had a real impact on me and made us feel tremendously cared for. I want to distinguish that from false advocacy. So false advocacy would be giving patients whatever they ask for based on expediency or exasperation. This is prescribing non-medically indicated care where there's a lack of evidence base, where there's potential for harm. I can give examples, but the idea that you're advocating for patients simply by acquiescing to every potential request they make is not, I would call that not advocacy. I would call that potentially threatening the integrity of the medical profession. And I think sometimes we have to be advocates of a fair process. I mean, our default position is we advocate for patients, right? And patient primacy is our default position, but rare examples where we have to ensure there's a fair process, and that involves our public obligations, right? And so whether that's the duty to warn, or whether that's scarce resource allocation considerations, whether it was during the pandemic or elsewhere, right? That's about fair, transparent, consistent application of a systematic framework that prioritizes patients who are most likely to be harmed by not having access to that treatment, right? And that's a fair process. It doesn't necessarily allow you to advocate for your individual patient. And I think that's very acceptable to the public. And it's particularly acceptable to veterans. I know they've looked at veteran populations and their attitudes about this. And in general, the studies indicate that they believe this is fair and it's transparent. And it's based on evidence, and those are the things that the public can accept about how those decisions are made. So let me switch to the institutional level. And the story I have about this is I was on a flight to SGIM years and years ago, and I ended up sitting next to David Himmelstein, who was a great single payer advocate. And we were chatting, and I said to him, I said, how do you decide what to study, what to write about? And he said, you know what? I find something that really pisses me off, and then I write about it because I'm interested. And like, I mean, I tell every resident that, and when they're interested in research, and it's incredibly motivating. And it also reminds me that most of what we do, and most of what a lot of us do in society, is solve problems in our work. And so I want to talk about institutional advocacy as a way of promoting health for a local community that you provide at the institutional level, right? So for those of us that are affiliated with institutions like hospitals and medical centers, thinking about that local population, that local group of patients who you're providing. So it's not just that individual. We're sort of moving out of that sphere that I showed before and thinking about a larger group than just the ones that necessarily show up in your office. So I like this quote, mostly because it's like almost 300 years old, and it's that patients have been ignoring doctors' advice for centuries, so it's not new. And for those that don't know, John Gregory was really one of the founders of Western medical ethics and moral philosophy, and his writings are very interesting. And most of it looks like something that could be written today. In some ways, it's a little gendered, but I like this quote because it illustrates a little bit about my own academic interest in against medical advice discharges. And so I want to talk, so an AMA discharge, against medical advice discharges, that's when a patient declines recommended care and chooses to leave the hospital prior to some clinically specified and physician recommended endpoint. And I want to tell the story of my work through AMA over the last couple of decades, because I think it's a path for a new type of advocacy, and it's at the institutional level. And these are conflicts of power and conflicts of leverage, and I was sort of related to those when I first got interested in it. I related to these patients. I found myself interested in these problems rather than annoyed or worried about liability. And things just sort of went from there. So, but what I noticed early on was that this problem was primarily guided and described and elaborated on by lawyers and by risk managers and by compliance officers and administrators. And I want to tell a story about how physicians and researchers and ethicists have sort of reclaimed this a little bit for this population of patients and how we can lead morally, right? So AMA discharge isn't a legal issue any more than any other clinical care we provide, right? But when we take moral leadership on this, we start to identify patient-centered solutions rather than relying on legal or rules-based solutions. And I'm going to talk a little bit more about what that looks like. So let's start with how some of these patients are typically described, the difficult patient. I would describe myself as a difficult patient. If I end up in any of your offices, you should be prepared. But the problem is, and this is generally how these patients were described in the literature, they're difficult. And the problem with that is obviously, right, these are embedded values, right? This is a pejorative description that's really not in alignment with professionalism, right? So as I was getting more interested in this, I saw that interesting investigators were looking at a different way to study this, right? And obviously you can't study difficult patients because that's not systematic. There's no way to operationalize difficult, right? Because my difficult is yours. Well, yeah, it doesn't bother me. I don't know. So we have to sort of change the locus of what we're going to study, right? And when we started to examine this, they described these as difficult doctor-patient relationships, complex clinical encounters, difficult to help. All of those describe the challenges of providing healthcare to certain types of patients based on their unique needs, right? But it's not pejorative, and it doesn't make it the patient's problem, right? It's a healthcare problem, and it's a problem of the professional that's caring for that patient. Okay. So I'm going to talk about why we should study this. I've given you a couple of reasons, and I'll talk about the prevalence is relatively low. It's about 2% of hospital discharges. It's going to differ depending on the hospital. Up the street from me at Bellevue, it's about 6%. At the VA where I practice, it's about 2%. So usually not lower than 1% in any hospital, but generally nationwide is about 1 to 2%. So you could say it's low prevalence, but I would like to suggest that it's important. When we understand these problems about conflict in healthcare, about challenges with engaging or disengaging with care, that spans beyond AMA discharges. AMA discharge is the end of the spectrum where the relationship is disrupted and there's concerns, immediate concerns about the patient's safety. But we all know these happen in other lower stakes scenarios. And so some of what we've been learning about and trying to improve clinical practices on apply in those scenarios as well. But also, it's this limit of the compliance model for care, right? And that's the idea that we don't think about compliance in the same way that we did in the 1970s and 80s, right? Whereas you write a prescription, and if the patient didn't take it, it was the patient's problem. That's not how we think about the complexity of providing healthcare. In the inpatient setting, it's not the idea of, well, here's the option, and either you take it or you leave, right? That's not how we think about it. And so we'll talk a little bit about how shared decision-making starts to apply to inpatient decisions about discharge and inpatient treatment as well. So we started with some normative research, and that involved some narrative reviews of the existing literature. And when I first looked at this, 16 or 17 years, I can't remember how long ago, most of the studies were on predictors of AMA discharge. I would say there were about 60 or 70 studies, and almost all of them just looked at the predictors of AMA. And they all sort of found the same thing, and it looked at patient factors. And it found that if the patient was young, or they were undomiciled, or they had a substance use disorder, or they had lower socioeconomic status, that they were more likely to leave AMA. But that was it. it didn't advance the field in any really way. And I don't, and the idea is that you develop interventions based on this, but no interventions had ever been developed for reducing AMA discharge. And this was a number of years ago. Now, the very few number of interventions are primarily targeted at patients with opioid use disorder. And the benefit of having medication-assisted treatment and addiction consultation services, et cetera. But really, there's been almost no interventions in this sphere to try and reduce the adverse impacts of AMA discharge. And the adverse impacts are essentially lower quality care. At least what's been studied are 30-day hospital readmission. So most studies show that there's probably a 1 to 2 times greater rate of 30-day readmission in patients who are discharged AMA. We also found that there was really no standard for what an AMA discharge is, no definition of what it is. There's no shared understanding about how clinicians understand what an AMA discharge is, call it, define it, et cetera. And that's problematic, right, clinically, because there's going to be a lot of variability in how clinicians apply this term. And I've had clinicians who are like, the patient didn't wait for their paperwork, and so we discharged them AMA, as opposed to, they ran out of the ICU, after extubating themselves, right? I mean, these are two very, different scenarios. But also, how do you study it if you don't have standards about what constitutes AMA? So, so there were some real challenges with looking at the literature early on. So we made the argument that designating a discharge as against medical advice was low value care. Let me just say, just to sort of set the level here, is that the primary obligation, and I'm saying this generally because it will depend a little bit within the state in which you work. I work in a federal system, so there are federal regulations and standards related to this. But essentially what I tell my residents and colleagues is that your primary ethical and legal obligation is to ensure the patient understands the consequences of leaving the hospital against medical advice, if they understand the risks and benefits, and you document that within the record. Beyond that, you have no further legal obligation. You don't have to use an AMA discharge form. We'll talk a little bit more about what some of those challenges are. But also, there's never, ever been any study that's demonstrated a benefit of discharging a patient as against medical advice. Not talking about the documentation, the conversation that you should have, but we've never, ever identified a benefit of designating that discharge, getting the patient to sign a form, et cetera. We do know that there's stigma and there's elements of coercion involved in these discharges. So an interesting study from the ER found that 25% of patients discharged AMA from the ER didn't want to return to the hospital because they didn't like how they were treated. There's a great study by a U of C medical student that looked at this urban medical myth, which is that if you discharge a patient AMA, that their insurance won't pay for the surgery. Great study, go U of C. They looked at 40,000 discharges. They found no evidence of any denial of insurance because the patient was discharged against medical advice. So that's going to undermine the quality of informed consent for patients, right? You're coercing them by suggesting that they'll have financial implications of leaving the hospital. And then the last part is this value of signing an AMA form, and you've probably all seen these before. Not an evidence-based form of risk communication, never been demonstrated, no clear indication of how that improves the quality of informed consent. It's primarily used to manage liability. It's written in legalese often. It's often not written at an 8th grade reading level. I've never had a patient go, "Thank you, this is super helpful. I can take this and bring it home," right? Now, do we believe in documentation and ensuring that we protect ourselves from liability and that we accurately describe the conversation we had with the patient? Of course. So generally, the push is towards a templated form in the chart that describes the nature of your conversation, what the patient was told, et cetera. And that's clear. And again, the risk managers and the lawyers and everyone else I've spoken to say that's going to address the legal concerns. But we're also interested in the patient-centered concerns, and that's where some of those normative considerations came from. So let me talk a little bit about rules and values. The most common question I get as an ethics consultant, or often by clinicians, are, well, just tell me what the law says, and then I'll be good to know what to do. And the problem with that from an ethics perspective is ethics can allow us to do so much more, right? So rules and laws set the minimum standard, the floor beneath which we can't go, but it doesn't necessarily inspire exemplary practices. And I work with lawyers all the time. I love it. Total non-overlapping skill sets. I work with general counsel, but I never ask general counsel, what should we do? Because they're not clinicians. And I don't want their opinion about what they think is best for the patient. I tell them what I think we should do, and I make sure that what I've suggested is not illegal or it doesn't expose the institution to liability. And it's a partnership, and we go back and forth, and I'm wrong sometimes, but it requires, again, experts in both clinical care and law to make sure we do that. And the reason I bring this up is because AMA discharges have been dominated by this liability focus. And it's not always from lawyers. I would say a lot of times it's from clinicians who are very concerned about liability. It's so much that it might affect their clinical mindset. So they're less able to see the patient's perspective. And the easiest people to talk to about this are my residents. When I tell them what they're required to do, they're sort of, their shoulders relax and they're like, oh, okay. And they're able to like engage with the patient on a much different level. And they're able to be much more empathic, and they're be able to be much better problem solvers. So I was just having a conversation before about how like our best friends are the risk managers in this scenario, because they can convince clinicians in ways that I'm not always very successful. But I think from an ethics perspective, we relinquish, as healthcare professionals, we relinquish professional leadership on this issue when we constrain ourselves and our patients to rules-based solutions, to legal rather than patient-centered considerations. And so when we lead with, well, what's best for my patient, rather than what does the law say I should do? And then again, we collaborate with our legal counsel, and we lead ethically, and we define patient-centered solutions rather than ones that are just focused on rules. So everybody talks about patient-centeredness. Not everybody understands what I used to say it without knowing what it was, and the 2001 IOM report opened up my eyes about that. And this was describing improving healthcare quality, and these were the 6 aims for improvement. They're not rank ordered, right? But if you're going to define 6 things to improve in quality, patient-centered was one of them. Like, that's a big deal. I'll mention Don Berwick now, who was the head of CMS, I think, when this came out. And one of the most important papers I've read in my career was an article by him, the references on the next slide, I think, that really helped me understand why patient-centeredness is so critical. But again, what's the definition of it? So it's providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Guide all clinical decisions, don't dictate all clinical decisions. And that we're thinking about it and we're respectful of those patient preferences. And then how do we operationalize this? Well, we do it through shared decision-making, right? And I like this definition the most, Glenn Elwyn, I think he's at Dartmouth now. An approach where clinicians and patients share the best available evidence when faced with a task of making decisions, and where patients are supported to consider options to achieve informed preferences. So this isn't just PSA screening. This isn't just mammography screening between ages 40 and 50, right? This applies to almost every clinical decision that we make in clinical care. I'm not talking about the size of the endotracheal tube that the anesthesiologist is going to use, but if you're an opera singer, you may not want to be endotracheally intubated because your career depends on your vocal cords. And so maybe there are options, maybe that's subject to shared decision-making, and maybe you're an LMA or some other alternative ability to deliver general anesthesia is appropriate. So we need to be thinking about it all the time. I like this graph because not everybody thinks, or some people think graphically. Sometimes I do, not usually, but. And this shows sort of how we think about this. So from an AMA discharge, right, this is the bar that we can't go beneath, right? That's that standard that we were talking about. So that if it's a request for a discharge treatment plan that's not in accord with accepted medical standards, then that would be considered substandard treatment, and we would call that against medical advice. And those happen. And I don't disagree with those. But everything above it is subject to shared decision-making, and all those different injections or different options. Now, the top one, that's the answer on the test, right? That's the correct answer on the test, but all the other ones are completely potentially appropriate based on what the other patient's values are, right? Now, I would love to say that I came up with this concept, but I didn't. Herbert Simon, Nobel Prize winning economist from the 60s, U of C graduate also, came up with this concept, this neologism, satisficing, right? And it's satisfy and suffice, right? And it's imperfect and less than satisfactory, but it's good enough given the constraints, right? So we sometimes make good enough decisions for our patients, not necessarily what we would primarily recommend, but sometimes appropriate given the constraints in the decision-making process. So let's move to the systems perspective. And I'm going to continue the story about AMA discharges because we were interested, again, most of the research was looking at patients. And we thought, well, from a quality perspective, there's got to be more, it's got to be more than just about the patient, right? What about the hospital? What about the provider? What about what's happening at the national policy level? Is that affecting AMA discharges as well? So we wanted to look more at that. And we, one of my colleagues and I did a lot of interesting work in this area. I think it's interesting. We wanted to understand the hospital and health system factors associated with AMA. We know almost nothing about providers that discharge patients against medical advice. Don't know if it's related to your gender or to how long you've been practicing or what region of the country you're in. We just don't know. And that's obviously that's part of the puzzle. It's not the whole part of the puzzle, but it's part of it. And we wanted to think about what was happening at the health system as well. So one of my colleagues at Bariana Koa back in 2009 started looking at this, and she found that for patients who were admitted for cardiovascular disease, their AMA discharge rate was much higher if their hospital was rated lower in quality. She used a number of metrics for determining hospital quality. So there started to think, well, maybe something about the hospital may be driving AMA discharges in some way or another. And so we looked in, what was it, 2020? I think we looked at, we wanted to look at the variation in AMA discharges across hospitals. And so we looked at the 2014 national inpatient sample. And what we found was about 7% of the variability in AMA discharges across hospitals were related to hospital characteristics. So we control for patient demographics, other hospital characteristics, and other national system level characteristics. And so some of that was related to the hospital. Now, it's not 80%, right? The biggest part was obviously patient factors. But that opened up the door and said, 7% of the variability is actually attributable to the hospital. What's happening at the hospital level that may be driving this practice? And then this was an interesting article, came out last year in JAMA, and they looked at racial disparities in AMA, and there was sort of conflicting data about whether or not certain racial groups had higher AMA discharge rates. What they found was that 12% of the variation in AMA discharges in the ER were attributable to hospital level characteristics. And what they found was that Black patients had higher odds of AMA discharge. Then they controlled for the patient demographics, and it was still significant, but it was lower. And then they added in hospital level characteristics, and the risk reversed so that they had lower rates of AMA discharge compared to reference population. And I think what I accept the conclusion that they made, but basically they said that Black patients were more likely to be served by hospitals with higher AMA rates. And that's an important consideration to make, right? That this isn't, again, it takes it out of the individual partially, right? And says from a quality perspective, we need to think about multiple levels, not just the patient, and not just saying, listen, the patient wants to go. Why is that our problem? So we took this in a new direction, and we wanted to look at the Medicare Readmission Reduction Program, right? So many people in the audience probably know about this. This is part of the Affordable Care Act, right? This was in 2012. And this was the program that started reducing payments to hospitals for higher than expected readmissions for these targeted conditions, heart failure, pneumonia, and acute MI. Now they controlled for clinical characteristics, right? Because hospitals taking care of sicker patients shouldn't be penalized for those readmissions. but they actually excluded all AMA discharges from this calculation. So the obvious question to us was, well, is this a financial incentive to discharge more patients against medical advice if they're not going to get dinged for the discharge? And I mean, anecdotally, I've had colleagues be like, just discharge them AMA. We won't get penalized for if they come back. So we wanted to look at that in a little bit more detail. So this is just our first descriptive study, and it just shows the rate of AMA discharges overall and for the targeted conditions over time. In 2012 is when the Affordable Care Act was implemented. And then we looked at higher rates of AMA discharge. So you see the AMA discharge rate is much, much higher, right? It's almost 12% in this population. But there wasn't a change that was related to the Affordable Care Act. So nothing definitive here, but suggesting that there may be a relationship between national policy and AMA discharge rates. And so then we wanted to look at this a little more carefully, and this is a commercial pay population, and this is the AMA discharge rates per thousand. And what we see here is there's an interrupted time series analysis. And so bar one is when hospitals were notified about the AMA discharge, about the Medicare readmission reduction program so that they could prepare. And then line two is when the penalties began to be implemented. So you see there's a significant change in the slope between after they were notified about it. And then the slope continued to go up after the implementation. And then we did a washout period where we washed that out. And then here we just use one interruption. So this is just when the Affordable Care Act was beginning penalties. And so that was a significant change in the slope of AMA discharges. So this told us that there's at least some evidence that the AMA discharge rate may be related to national policy. And this is a commercial pay population. Right? This isn't even the Medicare population. So their next step is to actually look in the Medicare population to see how this is affected. So we're back to the advocacy at a systems level. And this is the other end of the spectrum, right? This is on the opposite end of the interpersonal, right? For the patient in our office to the millions of patients across the country. And these are big problems. These are, I would say, the toughest problems to solve, but they're also the most powerful, right? And that's where we need collective action, and collection action is the hallmark of professionalism. And that's where we need organizations and organization to coordinate, set specific goals, educate and train our trainees, our medical students, clear messaging. It's all about messaging. And ultimately to change policy with supporting evidence and some participation in the political process, which is necessary. But again, I think it has to happen among organized forms of medicine in other ways. I think what I find the hardest part about this is that there's a dissociation between what you do and the result. And I think it's much easier when someone's in your office and you can advocate for them than when you do something small but important and you may not see an effect for some time. So it's just a statement. I don't have an answer for that, but I think it is one of the challenges that many people struggle with providing advocacy at this level. I think we all get a sense of the general obstacles, whether it's time, whether we lack the expertise, whether we're apathetic. I think fear and liability and threats to licensure are emerging concerns. I think the changes in access to reproductive health care in some parts of this country where clinicians are afraid of their licensure by providing what is otherwise medically acceptable care, legal in many parts of the country, but they worry about providing that care or advocating for it on some level. So what are the obstacles and what are overcoming them? So I like to say nothing will work, but everything might. So try anything, throw a lot of things at the wall. Again, don't expect immediate results from anything you do. I like this concept of conscientious practice, right? This is the flip side of conscience-based exemptions in healthcare, right? So there's very strong federal conscience protection statutes and at the state level as well for providers who wish to exempt themselves from legal, medically indicated care based on a religious or moral objection. Very strong legal protections for those people, right? The flip side, there is no legal protection. This is the conscientious provider, and I like that term, for someone who wants to provide medically appropriate care in line with the patient's preferences, in accord with widely accepted standards of medical practice, but is illegal in the state in which either they practice or where the patient lives. And I like this because it reframes it from illegal practice to conscientious practice, at least in our debates about this. Now, do I expect people to stand up and do this? This is, there's tremendous professional threat to do this. I'm not asking people to violate the law, but it does, for the people that do this, it asserts real moral leadership. And I think we owe some gratitude to those people that stand up and say no and dissent to what they think is wrong. So following these conscientious leaders is incredibly important, and I find very inspiring. But I think we need to also support and help people who are advocating. Thinking about this, I was talking with a colleague, and we were talking about the great John Lewis, the congressman from Georgia, and he talked about his freedom rides and when he was going through that, and he talked about the people that made the sandwiches for them, and drove them to where they needed to go, and the journalists that covered the work they did, right? And that was as important, he felt, to the work that he did, that it was a team-based sport. So we have to support and help the people who are doing this advocacy work. So start small, ask a question at a professional meeting, talk to your colleagues, talk to the lay public with the intent to educate and change opinions. As healthcare professionals, you lend veracity and legitimacy to these debates, and it's an incredibly powerful opportunity. But start small, write a letter to the editor, whatever it might be. And then finally, finding community. And I think this lecture series is an example of that, and I'm really grateful for U of C for organizing it and bringing together some thoughtful people in the field to think about this and get us thinking about how to do this better. Tremendous support in community, and I felt that in my time that I've been here. So with that, I'll take questions. Thank you very much.